Hello, good evening all. I'm Dr. Shweta, the course director and mentor at MRCOG. And today we are here to discuss the vulval disorder in pediatric and adolescent patient and their management. So this is a recent talk, and this is very important because most of the time, being a general gynecologist, we don't focus much on vulval disorder, and we do get them in emergencies to out of the hour services, and we should have knowledge of this to help with the right guidance and the right treatment for them. So first of all, I would like to congratulate all the Part 1 MRCOG Part 1 students who passed, and the MRCOG Part 2 students who passed in the January attempt. A heartiest congratulations to all of you, and thank you so much for overwhelming feedback from the successful students from MRCOG, which you can see at YouTube. So anybody who is looking for guidance for July exam for part 2, they can join this course, which includes free crash course. So if we talk about vulval disorder, this is one of the commonest complaints in pediatric and adolescent population. Actually, they will present as acute on chronic symptoms such as pruritus, discharge, soreness. Uh, the area is very sensitive for the young women like pediatrics and adolescent population because of the hypoestrogenic state, as well as because there is no hair protection because of no androgen. So they are very sensitive to get injuries as well as infection, as well as the chronic conditions, chronic irritation, the chemical irritations, cloth allergies, and many things. It becomes very important that we take a sensitive approach and do an age appropriate use of language, because the patient is either pediatric or adolescent. Both have different demands. Like for pediatric patient, you will have parents who will be narrating the story. For adolescent, they have a different need and demand, and they might like you to deal with them as they have the control over the situation. They want to know about it, and they might like to talk to you in private rather than being the parents present. So these all things we have to take care when we are consulting an adolescent population specifically, and especially in cases of pediatric, it will be the parent who will be giving the history. So history taking an examination needs a sensitive approach and a different approach for according to the age groups. As I told you, it is an hypoestrogenic state because the estrogen, the ovaries are still not functioning. It's not a pubertal age, still not hormone secreting. So hypoestrogenic state exposed, and neutral pH of vulva, because once the puberty attained, then it will be acidic pH of vulva and lactobacilli, which will give some protection to the infection. But for the young girls, this protection is not there. Adolescent age group will present with dermatosis, thrushes, infection, different kind of infection will be there. For young girls, they will be having mainly the GI, either GI tract or urinary tract infection will lead to vaginal infection. So it might be correlating, or respiratory tract infection because of the touch. It might go to the genital areas. And in adolescent, sexually transmitted infection is also quite common. So we have to be mindful about that. In terms of treatment, it will be conservative approach. Most of the time it will be reassurance and follow up to make sure that it has disappeared, and advice about the vulval hygiene is what is required most of the time. So as I told you, this is one of the commonest gynecological complaints in pediatric adolescent patient, and 50% of the presentation of the children emergency department actually have vulval symptom. So it's a substantial amount of patient presenting to ED. So it becomes the gynecologist's responsibility to understand how to deal with such situation. So today's discussion will definitely help you all in improving your clinical practice as well as knowledge about the young women, the young girls dealing with these kind of symptoms. Most of the time, it is the explanation, reassurance, sometimes topical treatment, advice on hygiene, bathing practice is what it requires for the resolution of symptoms. What are the main challenges? The main challenges in the young girls and the adolescent age group is the anatomy. Anatomy of the vulva in young patient is different because there's less fat because the labia minora is not yet developed, not yet fully having the adipose tissue because of the hypoestrogenic state. Sometimes you might feel the clitoris is more enlarged because usually we are not seeing the vulva of the children because it is a different branch, like pediatric gynecology sometimes. So yes, we should have the understanding and we should be mindful about the change in the anatomy of the young patient. The vulva looks different because of the underdevelopment, because of the hypoestrogenic state. It will be having a different view. At the same time, history and examination, as I earlier mentioned, become more challenging because you have to uh, deal with them with all the respect and privacy and confidentiality. And sometimes you have to talk to them separately when nobody is around. So these all things we should keep in mind. So what are the inflammatory and infective vulval disorders? Inflammatory, most of the time it will be inflammatory, non-infective. So if we see 80% are non-infectious causes, like dermatosis, like any skin condition, we have to be aware and we have to understand that vulval skin is also a skin, part of skin, body skin. So anything happening in the body, any dermatitis, any generalized skin condition might present in vulva as well. So 80% of the cases are non-infectious because of the dermatosis, chemical irritation. So yes, the soap irritation, sometime the odor, different chemical, different things they are using for bathing and for tubs and all can affect and can lead to presentation as vulval dermatitis or vulval dermatosis because that skin is more sensitive than any other exposed part of skin. So this is an inflammation of vulva and vagina. One of the commonest diagnoses when they're present with vulval symptom, 20% of all pediatric and adolescent gynecological referral to secondary care is due to the vulval conditions, and 50% of the ED attendance is with vulval symptoms. Most of the time it will present as acute on chronic, so it will be like redness, soreness, discharges, itching, and the peak age is 3 to 7 year old. So sometimes we don't think that so young girls can present with vulval problems, but it is commonly seen in this age group. If we talk about infection, the organism most commonly found are either related to gut because the anus is near the vagina. So any infection in the GI tract can be transmitted to the vulva and vagina because of the washing technique. If they wash from back to front, these all leads to GI infection to go in the vagina. The other could be respiratory tract organism. If any respiratory tract infection, the hand, because of the poor hand hygiene with the kids, they can't understand. So it will go in the private area and it can infect that area. So it could be E. coli, group A streptococcus, B. hemolytic streptococci, H. influenzae. These all are the infection organism found in the infective vulvar disorder. Now, vaginal yeast infection, Candida. Candida is not very commonly seen in the young girls, but it can be seen in the immunocompromised or diabetic children. So if uh, immunocompromised is a risk factor for yeast infection, that's why you will be able to see that commonly in these kind of children. So in exam, if you get a question of a diabetic children, immunocompromised children, then you should think about vaginal yeast infection as well as a differential diagnosis. Now, if you see severe vulvovaginitis, you should also think about systemic infection like measles, varicella, rubella, where all the skin is having the rashes and itching and blisters and different kind of appearance, and the same you will be seeing in the vulva. STD infection like Neisseria and gonorrhea and Chlamydia trachomatis, if you see that infection in the vulvar area for young girls or adolescent, you should think about sexual abuse, but at the same time, it doesn't preclude or it doesn't diagnose sexual abuse, but you should be careful about ruling out that, and you should do the referral to the safeguarding assessment. So focused history, very, very important. You have to ask for the symptom, what all symptoms she's having, if there is any prior episode, if there is any allergic or skin condition, if there is any urinary tract infection, GI infection, If there is any recent infectious disease, any pharmacological treatment, hygiene habits, any new chemical irritation like new soaps, new detergent, bubble bath, physical activity like cycling, horse riding, swimming, which can affect and can lead to new infection. Social history is important to rule out sexual abuse if there is enough progress at school, what is the family dynamics and all that things. And screening for sexual abuse is very, very important whenever you have a doubtful history. How you will examine the patient, either it will be supine frog-like position or supine lap position, where the baby will sit on the mother's lap and you can examine, or the baby can lie down and you can examine in the frog-leg position. Diagnosis and management, it is mainly a challenge because of the proper history taking and ruling out other conditions, and you have to also rule out the generalized skin condition so that you can give a proper treatment. Now, most of the time, the swabs and examination under anesthesia and invasive tests are not required because most of the time it is non-infective, and you will be able to make a diagnosis by just history taking if there is any predisposing factor, any chemical irritation, any physical activity, all these things, any urinary tract or GI infection. So these all will help you in diagnosing what kind of situation you are dealing with. Most of the time, if it is severe vulvovaginitis, you will see the erythema around the vulva as well as around the anus, and you will see some pruritus and redness and excoriation because of the itching. But most of the time, there will be just slight erythema around the introitus and no other signs. So it is tricky sometimes to diagnose, but yes, history and examination simultaneously will help you in making a diagnosis. And most of the time, investigation and invasive testing is not required. In terms of management, a conservative approach and strict hygienic advice at what it needs, and then the follow-up every 3 to 6 months to make sure that it has resolved. If the swab is positive, if you see any obvious discharge or anything, you can take a moist swab and send the swab for culture. And if you found any organism, then accordingly you can treat them with antibiotics. But swab is not mandatory. If you see any discharges in particular area, and then the moist swab will be helpful. So conservative treatment, what all you will advise for a vulvovaginitis is improved hygiene. You will talk about how to keep that area hygienic, not to wash too much, use cotton underwears. The same vulval care advice we give for old women that are also hypoestrogenic. The same like young kids who are also hypoestrogenic. So improved hygiene, wipe from front to back, because if back to front, then the GI infection will come to vagina. Avoid soap and bubble bath. Avoid tight clothing, tights and leggings. Avoid contact with known irritants. Urinating with knees apart. Leaning forward to avoid pooling in the vagina and forehead. Warm water soak for 10 to 15 minutes. Emollients and barrier cream containing zinc, for example, nappy cream. So these are just barrier will avoid grabbing the infection from different area, and it will help avoiding grabbing the infection from environment as well. Cotton underwear, nightgowns, treat constipation, and big yogurt or probiotics. Also, these all will be helping in avoiding the infection. So we saw that most of the time the vulvovaginitis is non-infective. 80% are non-infective. You can simply diagnose by history and examination. Swabs and investigation, examination and anesthesia, invasive testing is not required. And conservative treatment, reassurance, and follow-up is what is needed. In follow-up, you have to call them in 3 to 6 months to make sure that it has resolved. Always rule out the systemic infection like measles, mumps, rubella for the babies whenever you have any other signs in any other area of body. Now, have you ever thought about lichen sclerosis in the babies? Usually, whenever the lichen sclerosis name comes, we think about the old age. We think about it happens in hypoestrogenic state in the old age. But actually, lichen sclerosis can be seen in the young girls as well. So if you see how it is, again, the atrophic, whitening, cigarette paper appearance, thinning, then sometimes it will be scarring, and all these things can be seen even in young girls. And once you treat them, it improves and gain the normal architecture. So the pediatric population comprised 7 to 15% of all lichen sclerosis cases, which is quite substantial. And peak incidence is seen in pediatric community in prepubertal girls. Because of the heterogeneous nature of this disease, as well as many can be asymptomatic, there is often a delay in the diagnosis of 1 to 2 years. For the etiology of lichen sclerosis, it could be immunological, genetic, hormonal, or infectious. And in terms of genetic theories, 10% of the patient diagnosed with lichen sclerosis have first-degree female relatives with the similar condition. Again, because of the hypoestrogenic state in the young girls and adolescents, you can see it. Diagnosis and management will be same as adult. You will be the treatment will be clobetasol 0.05% clobetasol ointment, and because of the steroid, there could be many side effects of steroid uses. So close follow-up, 6 monthly to yearly is what is recommended. The other could be labial addition. Now, if you can see the labial addition, the labia has stick to each other. Why this has happened? Again, the same reason, because of the hypoestrogenic state, sometimes the labia can join and reepithelialize because of irritation, injury, any raw area, then it will stick together. So it is seen in 2% and 39% in girls aged 3 months to 3 years. So it's quite common. If you see, report prevalence of labial adhesion or labial fusion or agglutination is quite common. So we should have the understanding of this, that it could be natural, normal, and we don't have to do much just to reassure them. Most of the time it will heal on its own. So because of the hypoestrogenic environment and irritation, it has reepithelialized and closed. But if it is asymptomatic, you can just tell them that nothing to worry about. It will improve once the estrogen will start kicking in pubertal age, it will improve. But if symptomatic, it might lead to urinary problem like difficulty in urinating, either dribbling or infection, recurrent urinary tract infection. So these kind of situation, then you have to treat it. So most of the time reassurance, if it is symptomatic, then you have to think about medical treatment. So what medical treatment? Because it is a hypoestrogenic state, so medical treatment will be topical estrogen cream. So either Ovestine 1%, estradiol 0.01%. You will take on the cotton swab and then apply it in downward traction for up to 6 weeks, twice daily. Success rate is quite good, around 80%. It will resolve, which is good. If this doesn't work, then you might have to think about surgical separation, but they mention in the talk that is almost never required. Rarely it is required. And again, if you do it surgical correction, then there is a chance of recurrence, and 40% there is a chance of again gaining the labial adhesion. So you have to counsel the patient properly and tell them that surgery is something we don't prefer in such age group because of the recurrence, as well as we don't want to do the scarring there in such young age, where it is because of the hypoestrogenic state, it is not fully developed. So we usually want to wait till the patient attain puberty so that you don't damage an underdeveloped private area. So labial adhesion or agglutination, now you have the clarity about that. If you see such kind of situation in ED, you will not worry, and you will just you will just reassure them. And if it is too much symptomatic in terms of urinary tract, then you have to give them estrogen cream to apply and then follow up. Then comes the congenital variation of the vulva, like clitoromegaly, hymenal variation, and many others like urethral protrusion or skin tag protrusion around the anus. Now, clitoromegaly, most of the time, it could be either due to hyperandrogenic state at birth, or it could be later due to congenital adrenal hyperplasia, 21 hydroxylase deficiency, which is the most common. 90% of the cases are because of that. Sometimes the young patient, when you examine their vulva, you will see that because the labia minora is not having the adipose tissue, the clitoris will look bigger than usual for any pubertal girl or reproductive age group women. So you have to be mindful about the anatomical change in the young girl, as well as clitoromegaly due to hyperandrogenic state, and accordingly it has to be treated. Or sometimes in transgender, it will be clitoromegaly. Hymenal variation, if there is imperforate hymen or microhymen where the space is not enough, there could be recurrent urinary tract infection, or in cases of imperforate hymen, it will present as bulge, and this every month they are bleeding inside and collecting the blood inside and not passing. So hematocolpus and all such, hematocolpus and hematometra and such kind of things. You can simply do the cruciate incision or U-shaped incision and divide it. But this operation should be done after the women attain the puberty, not before that. Urethral protrusion look like donut sign, they say, or the urethral protrusion happens again because of lack of estrogen, and then the estrogen cream is the treatment. Sometimes due to chronic constipation and pushing to pass motion, there could be a skin tag protrusion around the anus. So this is not fissure or skin tag or fissure. This is just protrusion of the skin around the anus. So these are the different variation you might see in the young girls when you examine their vulva and vagina. Now, the most important thing is trauma and foreign body. So young girls, they are not aware of things. They are playing. Accidentally they might injure, and we might think that it is sexual abuse or something. So we should always take a careful history to see what happened exactly. So accidental trauma is common. Type of injury could be straddle, accidental penetrating, or insufflation injury. The commonest injury is straddle injury, 80% of the cases where the kids fall with full body weight on some sharp object, and that is what leads to injury. Penetrating injury could be due to the play toys like bathing toys and many other things like furnitures, like while playing, like cycle seats, and many things can lead to penetrating sort of injuries. So taking a proper history and avoiding the sexual abuse is very, very important. And if you see any trauma, most of the time conservative management and secondary closure. If laceration is deep or something, then you can think about closure. Otherwise, conservative management is enough. If you can't see the extent of the injury, or you're doubtful about the sexual abuse, then examination under anesthesia might be useful. If the bleeding from the vagina, vaginal tear, suturing would be very difficult in the child, so a small pack would be enough. If there is periurethral tear, difficulty in voiding, then Foley's catheter would be needed. So you have to think about the generalized appearance as well as how much deep and extensive the lesion is. Accordingly, you have to treat. Then comes the foreign body. This is commonly asked in the exam, that young patient presenting with recurrent bleeding or chronic purulent vaginal discharge, what it could be. So whenever there is purulent discharge, infection, or recurrent bleeding, because of this foreign body being here for a longer time, it could be forgotten pessary, it could be tampon, it could be like toilet tissue, toys, anything can go inside the vagina, small piece of toy, anything can go in the vagina and stay there, and then it can lead to infection there, and that will lead to purulent discharge, and because of the trauma there, it can lead to vaginal bleeding. So if recurrent bleeding or recurrent discharge, then you should think about foreign body if there is no history of trauma. Again, examination, how you will treat it. So examination under anesthesia, and then you have to remove it, because you can't do it in for a long time it is there. So there can be a lot of infection, a lot of oozing, bleeding. So you have to be careful. And young kids are very sensitive, so you have to do it under general anesthesia. Either you can use a nasal speculum, cystoscope, or a hysteroscope to retrieve the object. So this is very commonly asked in the exam. Be careful what exactly the words are: recurrent bleeding or chronic infection or chronic discharge with no history of trauma. Then it suggests foreign body. Then comes the anogenital wart. Anogenital wart, it looks like freckles. It looks like in old age skin tag, the same way it looks like. And it could be due to HPV infection, 1 to 4, but 6 and 11 are sexually transmitted, and these are the commonest cause of anogenital wart. Again, the conservative management is the best and appropriate, because more than half of the cases will resolve on its own in a year or two. Sometimes you will see it around the anus, sometimes you will see in the fold, intragluteal fold. So this is how it looks like. If the resolution doesn't happen by conservative management, you have followed up, then you should think about cryotherapy or medical treatment like imiquimod, or cytotoxic medication like podophyllene. These all will give a good result with the wards. And lastly, the sexually transmitted infection, especially in the prepubertal, postpubertal girls, you will see the highest rate of STIs, and most of the time it is human papillomavirus or herpes simplex. If vulvovaginitis, then trichomonas vaginalis, candida, or bacterial vaginosis could be the reason, but trichomonas vaginalis is sexually transmitted, then you have to look for the partner as well. As most of the STI is asymptomatic and the long incubation period, so it's important that you educate them about barrier contraception, vaccination for herpes, this human papillomavirus, screening programs, self-checks. These all are crucial for this age group. For looking for the infection, if there is any infection to report, because there could be sinister consequences if it is not treated properly, and how to avoid it is most important for this age group. So that's all about the vulval condition in adolescent and pediatric age group. It's not a big or vast topic, but it is very important that we understand it well, because if we don't have knowledge of it, it looks very scary, that how to examine a young vulva, what to anticipate, what could be the reason. But once you go through it, it looks like it's very simple and there is nothing much. A proper knowledge, a proper treatment, proper diagnosis is very, very important for the young girls, because they are very sensitive and it can lead to psychological impact as well on them. It's not only physical, but psychological also. So taking care of that is very, very important in young pediatric age group children and as well as the adolescents. So that's all for today. Whoever is looking for part 2 guidance for July can contact us on this. This is a fee and this is a course feature. It includes the free crash course as well. Thank you so much. If you like it, please subscribe to the channel and press the notification button so you get the recent uploads of the videos notified. Thank you. Bye-bye.